Good afternoon, everyone. My name is Jude Jaraki, and I'd like to thank the Foundation for allowing us to present this research and data. A few disclosures. Ron Aginski and Dr. Ari Hananel are co-founders of FUS Mobile and are also shareholders in Insight Tech, as well as Dr. Susan Lebang is a shareholder in FUS Mobile. So a little background, the sacral iliac joint pain in the setting of low back pain has a prevalence of 10 to 25%. And currently the treatments are pretty invasive. They include intra-articular and periarticular injections of steroids or local anesthetics, as well as radiofrequency ablation. That can either be non-cooled or cooled radiofrequency ablation, where they attempt to increase the RF power and increase the lesion size. So the SI joint itself is a collection of muscles and ligaments in an articular capsule, and it is innervated by the lateral branch of the dorsal rami from L4 to S3. And there is a significant amount of anatomical variability of the lateral branch as it exits the sacral foramina, and this poses a problem for RF ablation because the lesion, first of all, may not extend to the actual nerve site, and second, it would need to have a lot of injection sites to account for all the lateral branch variability that exists. And this makes MRG FUS a plausible solution to this problem because it is, first of all, non-invasive, so it eliminates the necessity of the injection and eases the procedure for patients, as well as it can create larger lesions by doing a sweeping ablation down the sacrum. So as you can see on the bottom right, in an instance of, this is the sacral foramen at S1, and on average, if we're looking at it as a clock face from 12 o'clock to 6 o'clock, this is the average range of where the lateral branch can be exiting from the sacral foramen. But in a specific patient, it may just exit at 1 o'clock, 5 o'clock, and 6 o'clock. So 2 to 4 o'clock is being unaccounted for in the ablation. And there has been published literature documenting the ventral curve and straight length and the transverse and AP diameter of only the first sacral vertebra in human sacrums in India and Oman. So the purpose of this study was to evaluate candidacy for focused ultrasound ablation of lateral branches of the sacral nerves in patients with SI joint pain. So this was done by retrospectively analyzing 50 CT scans in a sagittal and axial and a curved coronal manner of the lumbosacral spine, as well as 3D models of the sacrum were reconstructed. So on the list, on the right, there are a few measurements that are being done, and perpendicular distance is defined as the straight distance from the skin to the sacrum at a midpoint between the SI joint and the lateral aspect of the foramen, or the LSIJ. And then stepwise linear regression was done to identify the strongest predictors. So the first picture on the right shows that perpendicular distance. Perpendicular distance. So it goes from the skin to the sacrum at the LSIJ midpoint, and then the maximal distance is the line where it does not intersect with the spinous process going to that same focal point. Sacral curve length is the curve length from the top to the bottom of the sacrum going through each of the LSIJ midpoints. And this curved reformat allows for accurate locations of the LSIJ midpoint. And then the AP sacral thickness is the AP dimension of each sacral vertebral body at the LSIJ midpoint, and the height and the diagonal of the sacrum are the distance difference between the S1 to S4, between the S4 bodies at the LSIJ midpoints. So we found that the average perpendicular distance decreases as sacral level increases from S1 to S4 from about 58 millimeters down to 30 millimeters. And then the average sacral thickness increases from S1 to S2 from 37 millimeters to 46 millimeters, and then peters out rapidly to 9 millimeters. So the stepwise linear regression identified sacral level, age, and BMI as the significant predictors with a p-value of 0.001. Non-statistically significant predictors are gender and the curvature ratio that's defined as below. And you can see that the model was built to account for these predictors. And on the graph on the right, you can see that there was non-statistical difference between the left side and the right side. And then the perpendicular distance decreases as sacral level increases. So in the instances that the iliac crest overlies the LSIJ midpoint, a cone was created between the iliac crest and the spinous process. And the mean cone height, or the altitude of that cone, was measured to be about 76 millimeters. And that is to provide an optimal angle to access the target area at that LSIJ midpoint. And the same stepwise linear regression model was used for the same predictors, and it only found BMI to be a significant predictor. So in conclusion, this is the first study to do in vivo distances on CT scans, as elucidated below, for the average perpendicular distance of 41 millimeters, average apiosacral thickness of about 3 centimeters, curved sacral length of 12.5 centimeters, and an average cone height of 7.6 centimeters. And future preclinical studies are going to be needed to evaluate safety and efficacy of ablation at those sites. Thank you.
Thank you. Another important research. Any questions for the audience? No? All these evidences are very important for building a protocol eventually to do this in humans. Do you think that there is anything important with missing the anterior aspect of the sacroiliac joint?
Well, with the sacral thickness being quite large at S1 to S2, I don't think the anterior aspect of the sacrum is going to be affected with the thermal ablation from focused ultrasound.
I mean, in a potential clinical effect for the patient, for a patient?
It could potentially, but I think it's something we'll have to analyze when we do preclinical studies.
Thank you. Any other question? No? Thank you.
Thank you.